Hi everybody, I'm Dr. Yasmine Gawish, lecturer of periodontology and oral medicine. I think I'll be recording this lecture in English mostly because the lecture will be uploaded for the Malaysian system. Okay, and today we're talking about salivary gland diseases. First of all, we'd like to just remember some important points about the anatomy and physiology of salivary glands. If you remember, we have three pairs of major salivary glands. We have the parotid glands, submandibular, and sublingual glands. The parotid gland opens with Stenson's duct. This is the name of the duct of the parotid gland. And if you remember, when you took with us in the diagnosis section, the Stenson's duct opens in the buccal mucosa opposite the upper first and second molars with the parotid papilla, if you can remember how it looks like. Okay, then we have the submandibular gland that opens with Wharton's duct. This is the name of its duct. And the Wharton's duct opens in the sublingual papilla or sublingual caruncles. I hope you remember how they look like inside the oral cavity. Okay, and then we have the sublingual gland. The sublingual gland have numerous ducts. It has a lot of small ducts. These are called ducts of Rivenus. These are the multiple ducts you can see here. Okay, and it has a main duct. The main duct is called Bartholin's duct. Okay, the ducts of Rivenus open in the sublingual fold along the whole fold, while the Bartholin's duct, it joins the Wharton's duct and open with it in the sublingual caruncles or sublingual papillae. Okay, for the type of secretion from each of the major salivary glands, okay, the parotid gland, if you remember, it has purely serous secretion. The submandibular gland has mixed secretion, mucus and serous, and the sublingual gland has only mucus secretion. Okay, what about the minor glands? The minor glands, they are everywhere in the oral cavity. They are numerous. Maybe we have only the gingiva. It's the only part that does not have a minor salivary gland. Okay, although the alveolar mucosa, which is the part above the gingiva, separated from it with the mucogingival junction, okay, it has a lot of minor salivary glands. So only the gingiva does not have minor salivary glands. Okay, as we agreed, we have a lot of minor salivary glands, and they are named according to their location. If they are located in the buccal mucosa, they are called buccal glands. If they are located in the palate, they are palatine glands. In the labial mucosa, they are labial glands, and so on. In the tongue, they would be called lingual glands. Okay, and most of the minor salivary glands have mucus secretion. Most of them, except some of the lingual glands. Let's talk about the lingual glands separately. Okay, for the minor salivary glands located in the tongue, we have three types of minor salivary glands. First of all, we have the Weber glands. Okay, the Weber gland, they are located in the posterior lateral tongue. Okay, and we have the von Ebner gland. The von Ebner gland, they are glands associated with the circumvallate papillae. If you can remember, this is how the circumvallate papillae looks like under the microscope. Okay, the von Ebner glands, they are located beside it and beneath it. Okay, and their ducts open into the trench or the groove that surround the circumvallate papillae on both sides. Okay. And lastly, we have the Blandin and non-salivary glands. They are located in the anterior ventral part of the tongue. Okay, this is a picture of a mucocele that affected the Blandin and non-salivary glands in the anterior ventral part of the tongue. What about the type of secretion? We agreed that most of the minor glands secrete mucus saliva, mucus secretion. Okay? If we see here, the Weber glands will be like most of the other minor glands. It secretes mucus secretions. Okay, while the von Ebner gland, it secretes only serous secretion. And the secretion of the von Ebner gland, it also contains some enzymes for starting the digestion process. It contains lipase enzyme, for instance, which starts the lipid hydrolysis before the food enters the stomach. Okay, and last we have the blandin and non-salivary glands. They have mixed salivary secretion, mixed between mucus and serous secretions. Okay, what about the main items in the physiology of saliva secretion? Okay, here we have the picture that shows us the acinar cells and the ductal cells. Okay, if we focus on the acinar part of the picture, okay, we can see the acinar cells. These cells, they produce the proteins that are secreted in the saliva. Numerous proteins are secreted in the saliva, like the lysozyme, lactoferrin, immunoglobulin A, and so on. Okay, these are produced by the acinar cells. Okay, while producing the saliva or fabricating the saliva, okay, we need some water, because this is the main component of the saliva. How can we get water within the acinar lumen? Simply, sodium and chloride are transported by active transport within the acinar lumen. Okay, so we have water now between the acinar cells. Once the sodium and chloride are inside, they will pull along with them some water. Okay, in this case, the saliva within the acinar lumen, okay, it will be isotonic. It will be isotonic with the serum. Okay, because the same concentration of sodium and chloride will be inside the acinar lumen, and the same concentration will be in the serum. Okay, and same concentration of water. While the saliva is excreted or secreted from the ductal cells, okay, the resultant saliva is always hypotonic. It's not isotonic as it was within the acinar lumen. How would it be made hypotonic? The transport will be in the reverse direction. The sodium and chloride will be excreted into the serum, okay, and replaced by bicarbonate and potassium, resulting in the final saliva, which is hypotonic to the serum. Okay, meaning that the salt concentration in it is lower than that in the serum. Okay. What controls the salivary secretion? The salivary secretion is totally controlled by the autonomic nervous system. If the parasympathetic outflow is the overriding innervation, okay, then we will have fluidy saliva or watery salivary secretion. If the sympathetic outflow is overriding, then we'll have viscous or mucus saliva rich in proteins. Okay, what do we have? What is the saliva that we have in the oral cavity? Is it merely the salivary secretion secreted by the salivary glands? No. What we have inside the oral cavity is what we call whole saliva, which is the mixed fluid contents of the oral cavity. Mainly, it's made of water, along with some proteins that are secreted with the acinar cells, and some salts that are absorbed from the serum. And along with these, which are the main components of the saliva, okay, we get a variable amounts of gingival clavicular fluid, food debris, exfoliated cells, mucus, and so on. And all these components together, they form what we call whole saliva, which is the actual saliva that we have inside the oral cavity. Okay, what about the volume of the saliva? Normally, a normal person should secrete from 0.5 liter to 1.5 liters per day of saliva. But is it something that is stable or something that is fixed? No, it's very variable. The variation occurs because of a lot of factors. First of all, the circadian rhythm. While we're sleeping, the salivary secretion is very low. And during day, with eating, talking, doing all the activities, the salivary secretion is increased. Okay. Also, taste and olfactory stimuli. If we smell or taste some tasty food, or we smell some good food there, the saliva secretion will be increased. Mechanical stimuli also stimulate more saliva secretion. If the patient has a newly fabricated prosthesis inserted in his mouth, he will find that he has more salivary secretions. It's kind of mechanical stimulation. If you put something into your mouth, a pen or so, it stimulates more salivary secretion. Pain also increases salivary secretion, while stress, on the contrary, stress decreases salivary secretions considerably. If you are in an exam and you are under severe stress, you'll find that your mouth is very dry. Okay, it decreases salivary secretion. Also, hormonal changes affect salivary secretion. It may increase or decrease the amount of salivary secretion. For instance, pregnancy hormones would increase the amount of saliva secreted, while menopausal hormones will be, on the contrary, they will decrease the amount of secreted saliva. Okay, now let's go. What if we have a patient complaining of some salivary gland disease? We will be moving step by step today, okay, with all the items that you are used to record in your sheets, okay, to reach a final diagnosis. We'll start with the complaint of the patients. What are the main complaints for patients having salivary gland diseases? And then we'll go for history taking and see what are the items that we have to focus on in the history. While if we have a patient that is complaining from a salivary gland disease, okay, and then we go for the clinical examination. According to the complaint, we have various examinations to do, and afterwards we have a lot of special investigations that sometimes we need to use to be able to reach a final diagnosis for the salivary gland disease. Okay, let's start with the patient's complaint. What are the two main complaints for a patient that has a salivary gland disease? The patient will either complain of xerostomia, which is the most common complaint, or he will complain from glandular swelling or a mass that is palpated in one of his glands. Okay, and sometimes the patient will complain from both xerostomia and glandular enlargement at the same time. If the patient has xerostomia, this means that there is not enough salivary secretion in his mouth. Then the mucosal surfaces, they will be very dry. Once the mucosal surfaces are very dry, he will have some trouble while eating, speaking, swallowing, and so on. Maybe the patient will tell you that he has to sip water while eating. He can't swallow the food unless he sips water along with it. And of course, the mucosal surfaces will all be atrophied with the mechanical friction while eating and talking. He will have atrophy in the mucosal surfaces, and this will eventually cause burning sensation. Sometimes the patient would feel soreness in his throat. Okay, and of course, this mucosa will be very sensitive to anything that is spicy or salty or coarse food. Okay. These are the two main complaints, the xerostomia and the glandular enlargement or glandular mass. These are the complaints of patient with salivary gland disease. Okay, what about the history while taking the past and present medical history from this patient? We have to focus on two things while taking the medical history. The most important thing is the drug history. Why is drug history very, very extremely important for a patient complaining of xerostomia? Let's have a look on the items of the drugs that cause xerostomia. You will find that a lot of these drugs we are all using on a daily basis. Okay, the antidepressants, antipsychotics, they all cause xerostomia. Anticholinergic medication, antispasmodic that we all use on a daily basis, antihistamines that a lot of us need to use for sinusitis, allergies, and so on. The antihypertensive drugs, they cause xerostomia, and most of the Egyptian population has hypertension. Sedatives, analgesics, diuretics, of course, will cause xerostomia. Cytotoxic drugs, meaning the chemotherapy drugs, okay, they also affect the salivary glands. Bronchodilators, all these drugs cause xerostomia. So maybe the patient comes to you in the clinic complaining of severe xerostomia, okay, and you start thinking of certain severe diseases, and the whole issue is just he's taking some medication that is causing this xerostomia. Just change the medication or stop it, things will be back to normal. Okay. The other thing that we have to ask about in the medical history, the medical conditions. Two main conditions we have to ask about. First of all is the radiotherapy. Any history of radiotherapy, this is very important, and we will be talking about the radiation-induced damage in the salivary glands later on as a separate item. Radiotherapy is extremely important to take a history of, because it causes permanent damage to salivary glands. Okay, it may cause permanent and total damage to all the salivary glands the patient has in his mouth. Okay, and unfortunately this damage, as I said, is permanent. It's not something reversible. So if the patient has a history of radiotherapy 5 or 6 years ago and now comes to your clinic complaining of xerostomia, this is quite normal. Okay, and you should know that it is not possible to re-establish salivary secretion again, because the salivary glands already lost their function. Okay, and also we have to ask about the history of any autoimmune diseases like rheumatoid arthritis, systemic lupus erythematosus, scleroderma, any type of autoimmune or autoimmune disease or connective tissue disease. Why is that? It's very important. Of course, you heard about what we call Sjogren's syndrome. Okay, we will talk about it in more details later. But the Sjogren's syndrome, it has a primary form and a secondary form. The secondary form is always associated with some autoimmune disease. So if the patient has an autoimmune disease in his history, I would and is now complaining of glandular enlargement and xerostomia, then we should suspect that patient has secondary Sjogren's syndrome. That's why taking the history of autoimmune diseases is pretty important. Okay, what about the symptoms and signs that we might find in the patient's oral cavity that will assure us that the patient really has severe xerostomia? You have to notice that something important. Some patients complain of xerostomia, but they don't have that severe xerostomia, and they don't really have a serious condition or a real xerostomic condition. This is important to note. Sometimes, especially the perimenopausal females, sometimes the complaint is out of psychological issue. So we have to examine the patient to make sure that he really has severe xerostomia. Okay, what would we find? What will we find if we examine the patient's mouth? Okay, first of all, as we said, that the mucosal surfaces are all very dry. Once they are dry, along with the friction while talking and eating, the mucosa will be atrophied, okay? And atrophy and dryness, say in the lips, we have cracking and peeling of the epithelium in the lips. If we see the tongue, we will find that all the tongue papillae are atrophied. Tongue will be erythematous in appearance, very painful. Maybe we have some fissuring and cracking also. The buccal mucosa would be pale, corrugated, and so on. Okay, this is something. The other thing is that along with the xerostomia, we don't have the buffering capacity of the saliva. The patients usually have certain type of caries, okay, that is very similar to rampant caries. You know the rampant caries, because of the bottle feeding, it's very severe, very rapidly progressing, okay, and it affects areas of the teeth that are normally immune to caries, like the cusp tips, root caries, and so on. Okay, and as we said that this type of caries is very rapidly progressing and very severe and affects areas that are not usual to be affected with caries. Okay, another thing that the patient may complain of, or you can find it on clinical examination, he might have a candidal infection. Okay, because we don't have the washing action of the saliva, so the patient is liable to acquire any type of candidal infection, erythematous candidiasis, pseudomembranous candidiasis, any type of candidal infections. Okay, also the patient, when the saliva is not there, okay, the plaque accumulation will be increased, so the patient will suffer from gingivitis, gingival bleeding, and periodontal diseases. Okay, these are all things that you can see in the oral cavity and the patient will complain of. What about the signs that can assure you that the patient is really xerostomach? We have two types of examination that we can do to make sure that the patient is really xerostomach. We have first of all, the most important one is the tongue blade sign. In the tongue blade sign, you take a tongue blade and press it against the buccal mucosa of the patient and then slowly try to remove it. You will find that the tongue blade actually sticks to the mucosa when the mucosa is really dry. This is called the tongue blade sign. The other sign is the lipstick sign. What is the lipstick sign? Okay, we agreed that the lips will be very dry, cracked, and there will be peeling of the epithelium. Okay, so these shed epithelial cells, okay, mixed with the lipstick of the patient, we can find them deposited on the labial surface of the anterior teeth of the patient. Okay, so this is the tongue blade sign, which is more applicable, and we have the lipstick sign, which is, I think, not that applicable in our society. Okay, but if the patient uses lipstick, you will find the colored shed epithelial cells deposited on the labial surface of the anterior teeth. Okay, also we should try to massage the major salivary glands and try to extrude some of the saliva from the salivary ducts, trying to make some pressure on the gland and pushing the salivary secretion towards the orifice of the duct, okay, and test the type of saliva that is extruded from the duct. Okay, if it is colorless, watery, copious, this is normal saliva. If you find that the secretion, especially from the parotid glands, are very viscous, which is not usual for parotid gland secretion, then this patient has chronically reduced function. This patient is suffering for xerostomia for quite a long time. And also, if we can find any pus or cloudy exudate extruding from the orifice of the duct, this would be an indication of a bacterial infection. If we have pus, it equals bacterial infection. Okay, all what we have been talking about with the clinical examination up till now is the clinical examination of a patient suffering from xerostomia. What if the patient is complaining of glandular enlargement or a mass in the gland? We'll start examining the affected salivary glands by inspection and afterwards by palpation, as we are acquainted to and as we are used to do the examination. Any clinical examination, we start by inspection and then go for palpation for anything. When we palpate the major salivary glands, the normal gland, it should be painless, okay, it should be slightly rubbery in consistency, and I shouldn't palpate any detectable masses. This is a patient with parotid gland enlargement. We can see the elevation of the earlobe and the diffuse enlargement of the parotid gland. The other picture shows a patient with submandibular gland enlargement. Okay. If the enlargement that the patient is complaining of is painful on palpation, this means that the patient either has bacterial or viral infection or some kind of acute inflammation. He has some acute condition. Mainly it will be a bacterial or a viral infection. Okay? Neoplasms, if the patient has some salivary gland tumor, usually it will be painless. But this is not an absolute rule. Maybe some neoplasms, especially if they are late, they are discovered late, they might cause some pain. But most of the neoplasms usually cause painless masses. Okay, talking about salivary gland tumors, we have a rule we have to settle together, important rule, you have to put it in your mind, that the smaller the salivary gland, the more liable to malignancy it is. Meaning that if we have parotid neoplasm, they would be more likely to be benign. While the minor glands, okay, they will be more liable to have malignant tumors, more than the larger glands or the parotid glands. This is a rule that you have to memorize, that minor glands are more liable to malignant tumors, much more than the major glands. Okay. Also, we have to examine if there is any sign of malignancy, any clue that would give us, that would push us towards suspecting malignancy. These signs are very important, and they are general signs for malignancy. They are not that specific to salivary glands. They are general signs of malignancy. Okay, if we find ulceration in the overlying mucosa, like shown in the picture, okay, rapidly growing masses, fixation to the deeper tissues, and if we palpate malignant minor salivary gland with malignant tumors, we'll feel some induration. I hope you know what I mean with induration. Induration is that the lesion is firm but from underneath, because it is fixed to the underlying tissue. It's firm but from underneath it, okay, not its tissues itself. From underneath you feel firmness. Okay, if we find cervical lymphadenopathy, definitely we'll start suspecting a malignancy. For parotid tumors, we know that within the substance of the parotid gland, we have the facial nerve passing, okay? And some tumors have a tendency to make what we call perineural spread. They spread along the nerve, okay? So sometimes the facial nerve is involved when we have a parotid tumor, and this would manifest as Bell's palsy or facial nerve paralysis, okay? And some malignant tumors also cause some paresthesia. Okay, does that mean that when these signs are not there, that I can assume that the lesion or the tumor is perfectly benign and I can assure the patient that there is no problem? No. The picture that I'm showing you, this mass was, it has been there for many years, more than 5 years maybe. It was soft in consistency. You can see the mucosa is quite normal. It was bluish in color. First of all, we suspected some kind of vascular lesion, but when this lesion was biopsied, it was a mucoepidermoid carcinoma, which is a very aggressive malignant minor salivary gland tumor. Okay, so if you don't find these signs, this doesn't mean that everything is okay. It's definitely, you cannot assume that it is definitely benign tumor. No, it may still be a malignant tumor. Okay, now we're done with the clinical examinations, with the history taking, and with the patient complaint. Let's start with the special investigations that we might need, okay, to diagnose the salivary gland condition the patient is having. Okay, I want to make a deal with you. Okay, you will be hearing about some investigations related to salivary glands, like scalography, salivary scintigraphy, using plain X-rays to diagnose salivary gland diseases. I want to settle something with you. Most of these modalities are now kind of obsolete. Nobody uses them anymore. Okay? In the cyanography, they used to inject a contrast medium through the salivary duct, and afterwards take plain x-rays to try to detect if there is some kind of a salivary stone or something. Okay, in the salivary scintigraphy, they injected the patient with intravenous radioactive isotope, and then it take readings for the uptake of the isotope and the wash out of the isotope from the salivary glands and so on. All these investigations are very invasive, and now they are obsolete. Why are they obsolete? Because now we have other modalities that can replace them, that are minimally invasive, much easier, more accurate, and will give us more details about anything that we need. Okay, so we have to settle something, that the patient that has salivary gland disease, if I need some investigation after my clinical examination, I would go first of all for an ultrasound examination. Okay, I will do a Doppler ultrasound, and the Doppler now is an inherent part of the ultrasound examination. Okay, what I mean with Doppler, it assesses the tissue vascularities. Okay, it can assess the vascularity of the tissue and give us clues whether this is an inflammatory lesion, whether it is a malignant tumor, it's a benign tumor, or whatever. Okay, so we have to agree that once I need a special investigation after I finish my clinical examination for salivary gland enlargement or tumor or something, I will start with ultrasound examination. This is the first thing to request from my patient. Okay, this is very important. Why do we like the ultrasound that much? It's very safe, there's no radiation, it's available everywhere, it's inexpensive, and it gives us quite good information. Okay, an ultrasound examination can differentiate between the benign and malignant lesions in 90% of the cases. We can see the lymph nodes and make nodal staging to know the stage of the malignant tumor, if we have some kind of malignancy. And as we said, using the Doppler, which is inherent in the ultrasound examination now, we can assess the vascularity of the tissue, and we can use the ultrasound to guide us while taking a biopsy from a mass that is embedded in a major gland. Okay, so we can use it to take a biopsy, to get inside the gland, targeting the mass or the tumor. Okay, and we'll talk about ultrasound guided fine needle biopsy later on. Okay, so if I have a patient from his history and examination, I suspected salivary stones, cyatothiasis. Okay, we agreed that we start with ultrasound. If on the ultrasound I cannot go for a surgical procedure based on an ultrasound examination for the salivary glands. Okay, so the ultrasound will make it the first examination, and then see what we suspect afterwards. If we need some surgical intervention for the problem that we have, we'll definitely request another investigation, another imaging modality that gives us more details and is more precise than the ultrasound. So after the ultrasound examination, if we suspect a salivary stone, we can go for a CT scan or a CBCT scan. The CT scan can either a multi-slice CT, which is the CT in the radiology centers, or the dental CT, which is the CBCT. Okay? What if we suspect any other pathology? If we suspect Sjogren syndrome, if we suspect a tumor, if we suspect a benign or malignant tumor, whatever, here we go immediately for an MRI examination. MRI, it's very, very, very important tool for the diagnostic imaging of salivary glands. It's very, very important. Why is it very important? Because it has very high tissue resolution. Actually, sometimes they can characterize the type of tissue merely from an MRI examination. Okay, they can differentiate, the radiologists, they can differentiate inflammatory from neoplastic lesions based on an MRI, and they can differentiate benign from malignant tumors based on an MRI examination. And sometimes, based on how the tumor looks on the MRI, they can reach a final histological diagnosis from the appearance of the tumor on MRI. Okay, and this is very important. And sometimes this applies for diseases. For example, Sjogren's syndrome. Okay, it has very characteristic appearance in the major salivary glands on MRI, and the radiologist can just have a look on the MRI examination and say this is Sjogren's syndrome. So using MRI, we can sometimes, in some cases, reach a histologic diagnosis for the lesion that we have, or for the neoplasm that we have. That's why it's very precise, because it has high tissue resolution. This is a very important term. MRI has a high tissue resolution. Okay, plus, okay, we said it has this high tissue resolution, plus added to that, it gives us anatomical details that we need to know before going for surgical intervention. If there is perineural spread in the facial nerve or something, it will appear on an MRI examination. We can see the lymph nodes, make sure that they have metastasis or not, make nodal staging. Everything can be done with MRI. Okay, you will request the MRI from the patient that you suspect that has some disease or tumor in the salivary glands. Okay, when you get the report from the radiologist, you will find some sequences, names of sequences, basic sequences written in the report. I just want to give you a small hint about the basic sequences of the MRI, so just you can understand while you're reading the report. You won't interpret an MRI examination for a salivary gland. It's very difficult. It needs a radiologist. But I need you to have some information, some minor information about the basic sequences used in MRI, so when you read the report, you understand what is written out there. What is that written? So in MRI, we have 4 basic sequences. Okay, the first sequence is called the T1 sequence. In the T1 sequence, okay, it's called that it is fat sensitive and fluid non-sensitive, meaning that the fat will appear white in the sequence, while water will appear dark or appear black. This is a picture of an MRI examination T1 sequence. Okay, any head and neck MRI, you will have to focus on 2 areas. The area of the buccal pad of fat, the cheeks, okay, on both sides, and the occipital fat, okay, because these are areas that we know for sure that they contain a lot of fat, okay. And we have to look on the CSF, the cerebrospinal fluid around the spinal cord, and see what color is it, to be able to know whether the picture is a T1 sequence, a T2 sequence, or whatever. Okay, so here we will have a look on the buccal pad of fat, okay, the cheeks and the occipital fat, and we can see that they are white. Then the fat is white. And we can, here we should look at the cerebrospinal fluid, and you can see that it is dark or black around the spinal cord. Okay, and this means, this means that water is dark in this sequence. When we find that the fat is white while the fluid is dark, this means this is a T1 sequence. And here we can see the parotid glands on either side, how they look like in the T1 sequence of MRI. Okay, this is another picture let's look on the buccal pad of fat, the occipital fat, and cerebrospinal fluid. Again, we'll find that buccal pad of fat is white in color, occipital fat is white, while the cerebrospinal fluid is dark. Okay, this means that this is a T1 sequence. And here we can see the submandibular salivary glands. Okay, the second basic sequence is the T2 sequence. The T2 sequence, it is both fat sensitive and fluid sensitive, meaning that the fat and the water both will appear white in the T2 sequence of MRI. Here is a picture with the T2 sequence. We can see that the cheek fat, the buccal pad of fat or the cheeks are white, occipital fat is white, okay, while the CSF is also white. Okay, when all is white, then this is a T2 sequence. And here also we can see the parotid glands, okay, within the shadows of gray. Okay, this is another T2 sequence. Okay, the fat is white, CSF is white, then this is a T2 sequence. Okay, and here can we see the submandibular, normal submandibular gland on a T2 sequence. So the radiologist, okay, they know the X tumor, whatever, a special type of tumor. On T1 sequence, it will look so and so. On a T2 sequence, it will look so and so and so. Okay, on the other sequences, it will look so and so. From how it looks in each sequence, they will jump into the diagnosis. They can tell you that this tumor is most probably X tumor. Okay, did you get the idea? This is how they diagnose, and this is how they get the high tissue resolution and can reach the histologic type of the tumor only from the pictures of the MRI. Okay, I hope you get the idea. I hope I can make it clear for you. Let's continue with the other sequences. We talked about the T1 sequence where the fat is white, the fluid is dark. Then the T2 sequence, both are white. Okay, the third sequence is the T2 sequence with fat suppression, meaning that they stop this fat signal is suppressed. Okay, it doesn't appear white anymore, but the fluid is white. T2 sequence, the normal T2 sequence, we have both the fluid and the fat are white, right? If we suppress the signal of the fat, it will appear dark. So we only have the water or the fluid signal that is apparent and is white. Okay, this is a T2 sequence with fat suppression. Here we can see that the occipital fat is dark, the cheek fat is not that white anymore, while the cerebrospinal fluid is bright white, very bright white. And here there is some tumor in the parotid gland here, okay? And according to its appearance in this sequence, in other sequences, they can reach a close diagnosis. The fourth sequence in the MRI that is standard sequence is the T1 post-contrast sequence. In this sequence, they inject a contrast medium, IV contrast medium, inside the patient. Okay? And if you remember, T1 sequence, we had the fat should appear white, while the fluid should appear dark. Okay, here they injected the contrast medium and they did fat suppression. They suppressed the signal from the fat. So the whole background will be of dark tissues and only the contrast medium will appear white. Okay, this is an example of T1 post-contrast sequence with fat suppression. Okay, only the areas that took up the contrast medium appear white. Anything else is dark. Okay, these are the four main basic sequences of MRI. I will talk to you about, just give you a hint about two of the advanced sequences for MRI that are commonly used, especially with salivary glands. Okay, we have the MRI cyalography, which has totally replaced the conventional cyalography that has been made. and we agreed together that the conventional cyanography is now an obsolete procedure. Nobody uses it. Why doesn't anybody use it anymore? Because we have the MRI cyanography. It's non-invasive, very easy to do, and very accurate in its results. Okay, this is how an MRI cyanography appears. Actually, it is a T2 sequence with fat suppression. Okay, so only the fluid will appear white, and they take a very small section and concentrate on the area of the ducts. Okay, of course, the cyanography, we use it for the patency of the ducts. We use it when we have some problem with the ducts, and the most common indication for MRI cyanography or the conventional cyanography is salivary stones or cyalothiasis. Okay, here we can see that they focus on the area of the duct using a T2 sequence with fat suppression, so the whole background is dark and only the area with the saliva pooled inside the duct appears white. Okay, here is the salivary stone, if you can see, and we can see the white color of the saliva pooled within the duct. Okay, another one of the advanced sequences for MRI is the dynamic T1 post-contrast enhancement sequence, what we call DCE. Okay, this type of examination, it's a type of MRI examination, and it gives us an enhancement curve. It gives us a curve. Okay, the curves tell us the rate of enhancement or the uptake of the contrast medium. Actually, enhancement, we mean uptake of the contrast medium. Okay, so it gives us an idea about the rate of enhancement of the tumor, okay, and the rate of washout of the contrast medium from the tumor. It is well known that a malignant tumor will have rapid enhancement, okay, or early enhancement. It takes up the contrast medium very fast at the beginning, and then it has rapid washout, and it loses the contrast medium very rapidly also. A benign tumor will have progressive enhancement. It will take the contrast medium gradually, and then either reaches a plateau, okay, it takes the contrast and retains it inside, or continue taking the contrast medium. Okay, so it's either progressive enhancement, continues taking up the contrast medium, or it reaches some point and then plateau is there. Okay, it doesn't take more contrast and doesn't wash it out either. Okay, so using all these sequences, using all these MRI examinations, the radiologists are able to reach with a high degree of accuracy the type of the tumor, or give us a proper differential diagnosis for the tumor that we have. Okay, I hope you got it. I know this part was a little bit tough. I hope you got it, and if you want any more clarification, just tell me in your comments. Okay, the last type of investigation that we can use for diagnosing salivary gland diseases is salivary gland biopsy. The most commonly used type of biopsy is the minor gland biopsy. And the main indication for using it is the Sjogren syndrome and things that mimic Sjogren syndrome. Later on, when we talk about the diseases, we'll find that hepatitis C sometimes gives symptoms that mimic Sjogren syndrome, and HIV gives symptoms that are very close to Sjogren syndrome. Okay, all these diseases we can take a minor gland biopsy to confirm the diagnosis from. Okay, what we do in the minor gland biopsy, we make a superficial incision in the lower labial mucosa. This was a case that in our clinic, and we actually took, it was suspected for Sjogren, and we actually took the minor gland biopsy for. Okay, just we make a superficial incision, and you will find if we just push the salivary glands a little bit, you'll find them bulging from the incision line that you did. Okay, you have to collect about 6 to 10 minor glands, okay, and subject them to histological examination. And then we suture. It's very, very easy procedure, very simple and very minimally invasive procedure. Okay, what if the problem is not Sjogren syndrome, and what if we have a tumor in one of the major glands? Then we'll have to go for a major gland biopsy. And sometimes, along with Sjogren syndrome, after it is diagnosed, sometimes they use major gland biopsy to assess the response to treatment and the disease progression of Sjogren syndrome, and we'll talk about it. Okay, if we want to take a major gland biopsy from parotid or submandibular gland, we have to use an extraoral approach. We have to access them extraorally. Okay, what are the indications for this major gland biopsy? Mainly, it is neoplasms, lymphomas, which is a kind of neoplasm because the parotid gland has a lot of lymphoid tissue. Okay, that's why sometimes we need to take biopsy from it. Okay, and as we have just said that for Sjogren syndrome, it's not for diagnosis. We cannot use a major gland biopsy for diagnosis of Sjogren syndrome. We can only use it for assessing disease activity and response to treatment. Okay, this has several advantages, assessing Sjogren syndrome with major gland biopsy, though it is a highly invasive procedure, but it has some advantages. The first advantage is that we take the biopsy from the same gland. If we take minor gland biopsy, okay, each time we take different glands, okay? But if we take from a major gland, every time you will take the biopsy from the same gland, which is you already made sure that it is affected with the Sjogren syndrome. Okay. Another advantage is that we can take saliva samples along with the biopsy. We can take some saliva samples from within the gland. Okay. And with Sjogren syndrome, it's very, very common that later on the gland has the lymphoid tissue within the parotid glands are affected with what we call mucosa-associated lymphoid tissue lymphoma. It's a kind of lymphoma that affects the lymphoid tissue within the parotid gland. Okay, so if we take a biopsy from the major gland, from the parotid gland, you can take the salivary gland tissue along with lymphoid tissue biopsy to assess whether the Sjogren caused a lymphoma or not. Okay. It is, as we have just said, it is an invasive procedure, very invasive procedure. Okay, so it has the risks of if the healing is not proper, we can have a fistula that oozes saliva from outside, from the skin part. Okay, sometimes while taking a biopsy from the parotid glands, maybe the facial nerve would be injured. Okay, sometimes the incision from the skin causes some scarring and it is visible and it's not sightly because the parotid gland is in the face. Okay, this is very anesthetic. These are all the disadvantages or risks of major gland biopsy. To be frank with you, what we really use is the minor gland biopsy. Using major gland biopsy, it will only be used for when we have a real tumor. We have a big problem and we don't have any other option except to take a biopsy from the tumor itself. Okay, is there any other way to take a biopsy from the tumor itself without making the invasive procedure of major gland biopsy? Yes, there are two ways that we can biopsy a mass in the parotid or submandibular gland without going for a major gland biopsy with extraoral approach. We can use what we call a fine needle aspiration biopsy or a core needle or two-cut needle biopsy. Let's start with the fine needle aspiration biopsy. The fine needle, it's a special needle, okay, we insert it under local anesthesia. Sometimes it's inserted without local anesthesia either with or without. Okay, it is inserted into the mass that we have. Okay, and then with the piston of the syringe we make some negative pressure. When we make this negative pressure, it aspirates cells directly from the mass that we have. These cells are subjected to histological examination, and it gives a clue about the type of tissue that caused the tumor, gives clues about the type of the tumor and whether it is benign or malignant from the shape of the cells. The other option that we have is the true cut needle biopsy. Okay, what is the idea of the true cut needle? In the true cut needle, we have the main needle, which is the black part inside. And if you can see, there is a trough in this part. In the needle, we have a trough that is obvious in the picture. Surrounding the main needle, you have a sheath, a sharp sheath surrounding the needle. If you see the needle, it's like a gun. It is triggered first, okay? When it is triggered, you get the needle, like the second picture here, okay? You get the needle outside the sheath, and it is inserted inside the mass. Once the gun is triggered, the piston of the gun is triggered, the sheath runs very fast, okay, to cut a part of the tissue from the mass and harbor it inside the trough of the needle. Okay, the result that we have a small piece of tissue lying in the trough of the needle of the true cut needle. Okay, let's see how it looks in real life. This was a case with lip enlargement, and we took a biopsy from this enlargement using the true cut needle as shown in the picture. And this is the picture of the piece of tissue that we harvested inside the trough of the true cut needle. Okay, this was another case with a minor salivary gland tumor, and we took a biopsy from it with the true cut needle again, and it was diagnosed as pleomorphic adenoma. Only from a true cut needle biopsy we reached the final diagnosis. Okay, we can use the ultrasound to guide the needles, okay, to guide whether we are using fine needle or a true cut needle. We can use the ultrasound, okay, to guide the needle to where the mass is, so we do not do a lot of manipulation inside the tissues. Okay, we do it. The ultrasound probe is placed on the area of the tumor, okay, and we can see in the screen of the ultrasound machine, okay, where exactly the mass is, and we can go with the fine needle or true cut needle directly to the mass and take our biopsy. The last thing from the special investigations that we can use for diagnosing mainly the Sjogren syndrome is the serology, and I will postpone this part when we talk about Sjogren syndrome in details. Next time we'll be talking about the classification of salivary gland diseases and start talking about each disease in more details. Thank you, and please, if you have any questions, just let me know, and I hope everything was clear to you.